Building a family can be a complicated, messy, lonely, and sometimes heartbreaking process. But you don't have to navigate this challenging journey alone.
Welcome to the All Paths podcast, where we support and celebrate all of the different ways there are to try to grow your family. We are your hosts, Kate and Emily from the nonprofit organization All Paths Family Building. And today we're talking with a dear friend of ours, Dr. Malcolm Kip McKenzie, about his work in this space. Kip, thank you for joining us today.
I'm thrilled. Thank you for inviting me. I feel very privileged.
Well, we are the ones who feel privileged to have you. So before we talk in more detail, we'd love for you to just briefly introduce yourself to our listeners.
Yeah, so I am a 35 years practicing obstetrician gynecologist, the full range of OBGYN care, and with a special focus actually as well in the latter 20 years on complex endometriosis as a disease entity and a treatment focus. And I just recently retired and actually am pouring myself full time into training surgeons how to perform the complex surgical sort of approach that is sort of the not the newest, but certainly probably the most effective treatment that has emerged over the last 100+ years. So anyway, so there's a thumbnail sketch.
That's great. We love it. Well, and we're going to get into all of that, which we're really looking forward to. Are you a lifelong New Englander?
Well, actually, you probably heard a flat accent, so that puts me square in the Midwest. But yeah,
Oh, okay.
outside of Cleveland, Ohio is where I was
Oh,
born.
okay. I was just curious.
Yeah, and no, I wish I was, but then 1969 moved to southwestern New Hampshire with my family.
Wonderful. Well, so endometriosis is so dear to us here at All Paths Family Building for many reasons. But of course, probably the most obvious is just because of the intersection between endometriosis and fertility struggles. But also, obviously, just as an overall full body, full human condition, we are so passionate about improving the identification and care of endometriosis. And you are such a champion of this in every way throughout your career. And so we just want to start by saying thank you for all of that.
You're welcome.
But one thing I love is that you are not afraid of being provocative. And so one thing that I've heard you say some variation of at the beginning of whether it's a hearing at the State House or another event is I am part of the problem. Some variation of that. And can we start there? Can you talk about why you kind of make that confession so often?
Yeah. Mainly we make confessions because we are guilty, but so I shall explain my guilt most importantly. Being traditionally trained in OBGYN in the early 90s, I understood endometriosis as being a chronic condition, never can get rid of it, and you can never treat it. And then growing out of that comes a whole variety um, of things that are said in the course of clinical care with a patient with endometriosis. So I'll give you the full confession. It has passed my vocal cords the following. Oh, if you could just like to a 16-year-old or an 18-year-old, if you could just get pregnant, that would cure your endometriosis. A very inappropriate statement.
I have had that said to me. I think I
Uh,
was 15.
yeah.
Yep.
Number one, so that has, but more importantly, that statement is wholly based and founded on a really bad understanding, wrong understanding of the origin of endometriosis and the whole approach of endometriosis being very wrong-headed. Let me give further confessions. Ma'am, you'll never get rid of this. And if pregnancy doesn't work, then I can take out your uterus and take out your ovaries. And that will be the definitive treatment for your endometriosis. So let's just posit that for the moment and say, okay, here is a disease over here. And here's the more of the disease here or here and here. And now I'm going to take out your uterus and your ovaries. So now, even more incomprehensible is that we have a standard of care that says that the treatment of a disease is to take everything else out except the disease. And I was a full participant in that in my early years. And likewise, another thing that happens, unfortunately, given my frail ego, is if I couldn't improve somebody's well-being, I couldn't improve their health, then my response was to blame them for not wanting to get better. And so, too, the most painful one is I engaged in sort of subtle blaming of a patient for not wanting to get better when really the failure was mine to provide her relief. So that came in many, many different forms. And so, as a consequence, as I was working through the treatment of endometriosis, as I learned it, and was going in laparoscopically, identifying it, biopsying it, sending it to the pathologist to get a confirmation of diagnosis. If I had just listened to this patient who described missing middle school because of her period, missing all her favorite activities, I could have known the diagnosis, but I didn't because that was not part of my knowledge base, etc. But instead, I followed the dictates and I said, I'm going to do a laparoscopy, took the biopsy, and then would burn like I was told. I felt a little deficient because I didn't have a laser at the time by which to burn the endometriosis. And I I would wake the patient up and I would say to her, I got all your endometriosis, subtext, all of what was not near critical structures. I got all the endometriosis I possibly could, but I might have left a little, subtext. I left a lot because most of the surfaces in there are next to very critical structures. But I didn't want to do any on the bowel, ma'am, because I didn't want to injure the bowel. And here's the crowning statement, because you might have had to have a colostomy. Boom, she says. And the woman, based upon my inadequacies, says very kindly, says to me, oh, thank you, doctor, for not giving me a colostomy. You did everything right, etc. When what she should have said at the time was, where the hell was the inadequacy of your training to deal with endometriosis properly? Where was that inadequacy in your training that you could not give to me complete removal of my endometriosis without injuring the bowel? But instead, again, she very kindly said, oh, thank you so much, doctor, for not injuring my bowel and giving me a colostomy. So I learned many, many techniques by which I could deflect and move patients away from expectations that I did not know how to meet in terms of endometriosis. And as a consequence, I had burned endometriosis a little bit 1 year. And 2 years later, like an annuity, or 1 year later, she'd come back with continued pelvic pain. And I'd say, oh my gosh, erroneously, you got more endometriosis back. Not that I left any. Oh, of course not. I didn't leave any. But you got your endometriosis back, and I'll go back in and burn some more. So I'd go back in, and all that would repeat until finally I said, I can do a hysterectomy and take your ovaries out, et cetera, et cetera. Or maybe you try getting pregnant. And there's all these other things. And finally, then I take the uterus out and the ovaries out. And guess what? She's still not better. At which point I then said, have you had a history of abuse? Well, sadly, 1 out of 5, 1 out of 8 women have. So she had a high likelihood of saying yes. And I'd say, well, that sometimes will make for pain in the pelvis. So now there I am blaming the patient or blaming her history of abuse for the fact that she has pain. Or then, you're not trying very hard to get better here. And let's not hold to this pain because, it's all illusory. There's no cause that I can find it because your endometriosis is gone. No, I took the uterus out and they took the ovaries. I left the disease. Anyway, so on this goes. So these are some of my high point confessions to you, and begging for, a absolution. And that absolution comes in the form of trying to learn this disease, trying to figure it out because there's not a lot of basis to go, but following a little bit of what there had been early leaders in endometriosis care, following their guidance, which said, listen, what a concept. Why don't we take out this disease, all of it? And guess what? It doesn't grow back. It's not a disease that keeps spilling out backwards through the menstrual tubes every month. It turns out it has an origin as a single embryologic event at the age of 6.5 weeks gestation, a single embryologic event, call it mistake, wherein the one dose of all the endometriosis a woman will ever get is given to her at 6.5, 6 weeks gestation. She won't get more of it based upon the paradigm that it's what Sampson's theory, backwards menstruation. You get one dose of all the endo that you'll ever get given to you at 6.5 weeks gestation. And it awaits, lurking there until one starts at age 8 to have those tummy problems. And oh, she's such a picky eater. She's grazing to find what agrees most with her now endo affected intestines. And she's saying, oh, I can't tolerate that. And I can't tolerate that. Oh, such a picky eater. And then finally, the full bore of it is found at the age 11 when she starts her first period and she's totally knocked out of school and totally knocked out of her favorite activities. And voila, you now have endometriosis in its full manifestation. But now, unfortunately, and I've engaged in this as well, you have a kiddo coming in to the nurse's office and saying, oh, I'm, pale and sweaty, cold sweaty, and throwing up in the bathroom, etc. And the nurse with white coat authority, first real white coat authority, maybe the pediatrician in addressing this menstrual pain, that school nurse lovingly, well-intentioned certainly says, oh, honey, welcome to being a young woman. You just got to toughen up. You just got to woman up a little bit and, embrace your womanhood, etc. Second white coat authority, pediatrician, because her periods are really knocking her out 6 months in a row. Pediatrician, in sort of professionally and certainly intending well, says, oh yeah, it sounds like you just got bad periods. Parents lovingly and well-intentioned say, oh, welcome to the family, honey. Your great Aunt Edith from Keokuk, Iowa, she had wicked bad periods her whole life. And by the way, she never had kids either. Wouldn't wonder that. So we have this whole thing built to really take what is a highly abnormal thing. And I was trained to take this highly abnormal situation and almost treat it as normal. So there's part of my hundreds of different confessions I can make. And again, I ask of you your absolution.
Well, yes, I give it freely. Not that I have the authority to do so, but I mean, I do feel like you are too hard on yourself because you have more than made up for your earlier misinformation. But I'm not just saying that because obviously the remainder of your career has been completely devoted to making this better and to making all of those mistakes better, but also because you were, in my mind, a victim, as many are, of vastly insufficient and inaccurate education, as you touched on a little bit. And also, part of why I mentioned it was not to make you feel bad, certainly, but was because as an advocacy tool, I find it very powerful when people say, I thought and did this, and then I learned better, and I've done better ever since. That is powerful because people don't like, I think they take it a different way when they hear that from someone who wasn't perfect, didn't, isn't holier than thou, but is saying, I was part of the problem But again, I don't think this is a shortcoming of yours as an individual. I think, and unfortunately, it's still the problem. The training around this is so inadequate, and our thoughts about this condition are still so outdated and wrong.
Yeah.
So I don't know if you want
And
to touch on that separately,
yeah,
you
no,
can.
absolutely. That's a perfect opening, and thank you. But the critical piece is when in medicine in general, if we have an origin paradigm properly understood, then that will guide correct treatment paradigms. If you start out with a flawed origin paradigm from a disease, you get a flawed treatment paradigm. So now, we do not end up trying to close the blinds during to prevent COVID from affecting us. And we don't, you know, say 100 prayers thinking that that will do the trick on preventing a COVID infection. No, we understand it as an origin. Well, some people do. But anyway, as the origin of a viral infection, and thus we're going to treat it as a viral infection and not steer away from that and do something else. So too, endometriosis, and you know this well, but the the sort of origin theory that was established pretty well in 1927 by a well-intentioned physician named John Sampson, upstate New York. He was actually a pathologist there, um, and importantly, he had been opening up patients. Now, interestingly, he was a pathologist, so possibly he was seeing, some 1927 farming accident, which claimed a life, would open them up and look in and find these dark powder burn lesions. Looked at them under the microscope and said, "Oh my gosh, that's menstrual tissue." And then was asking the question, I wonder how the menstrual tissue that should be inside the uterus got over to there outside in the pelvis or the abdomen or whatever. So he started positing a theory that, oh, I know. As he looked at different things, he said, oh, look how some menstrual tissue is actually in the blood vessels or in the lymphatics of the uterus. Ironically, he never said in his original paper in 1927, he never said, oh, here it is spilling through the tubes and dumping out. That was simply an extrapolation, free form extrapolation of what he had written. And everyone then jumped on this very simple, sort of mechanical concept of a very complex origin, latched onto the simple concept that it is a backwards menstruation through the tubes. And that, as I said, is still in textbooks in 2026, not but 99 years later. So, with the wrong origin paradigm saying it's backwards menstruation, let's run through the conclusions of what therapy might be. A, you blame the uterus. So, taking out the uterus should stop all future endometriosis being laid down. Two, this is menstrual tissue, so therefore we know, anybody, a medical student knows, that if you give estrogen to somebody, it'll stimulate their menstrual tissue inside the normally placed menstrual tissue inside the uterus. And so, too, by that extrapolation, if that's called endometriosis over there, which is menstrual tissue, then yes, estrogen will also stimulate that. So those are conclusions from this origin paradigm. Thus, take the uterus out and starve it of its origin of estrogen. Thus, a standard of care, surgical care, that is still extant in 2026 as how to treat endometriosis. And I pointed out the absurdity. But let's just take a peek at just for the exercise of skepticism. Let's take a look at what it means then that it's retrograde menstruation. Retrograde menstruation, if that's the origin of the disease, should that not show up in a woman who's not yet got her menstrual period? No, it should not be there. Interesting. Then how do I explain that women, young women who have not yet had their period, have endometriosis? In fact, I can say, how do we explain that fetal study from 2012 that identified 101 female fetuses sadly lost as miscarriages, wherein 9 of those fetuses had endometriosis? And interestingly, in that study, those fetuses had endometriosis in all the places that are identified where endometriosis shows up in adult women. So now, maybe it's too much mathematical convenience. I have 9 fetuses in a cohort of 101, which by government work, that's 10%. But I've got a fetal cohort that actually represents and implies an incidence of endometriosis that is seen in adults, and likewise in all the locations that endometriosis shows up, bowel, bladder, in the little muscle wall of the uterus of that little fetus shows up called, oh, that's right, because guess what? Well-intentioned John Sampson could not figure out how endometriosis burrowed its way back into the muscle wall of the uterus. So he figured that couldn't be actual endometriosis. It had to be something else. So he called it something else called adenomyosis, when it's no more simply than endometriosis being located in the muscle wall. So we now have, in a in a sense, these. Oh, and wait a minute. How do I explain that men have endometriosis if it's backward? How do I explain that the same incidence of endometriosis shows up in women whose uterus never even formed, by which they could then backwards menstruate? And if every time I menstruate, each next month, I'm in a sense laying down another potential dose of endometriosis. Should it not be a cumulative disease? That is, stage fours are heavily represented in the woman who's 40, and stage threes are in the woman who's 30, and stage twos, and etc. And the answer is no. And that's been well demonstrated. The average amount of the number of endometriosis implants is the same across all age groups. So, in a sense, the implication of that epidemiologically is that it's a static disease, that you don't get more of it over time. We'd see something very different. But again, the crusher for that whole theory, or origin paradigm, is the fetal studies, and that's been replicated after that. So we have this disease that, okay, what's an alternate theory? Okay, well, maybe it goes through the lymphatics. Maybe rare cases of not super rare, but rare cases of endometriosis that show up in a C-section scar. Maybe that is indeed where that menstrual lining spills out at the time of opening the C-section, getting that baby out, getting the placenta out, where indeed those little rests or little tiny specimens of the menstrual endometrium, the base layer, gets into the incision and is closed in. Maybe there are other very rare circumstances by which endometriosis sets up, but in the main, absolutely in the main, a different origin has to be sought other than retrograde menstruation, because it doesn't add up in any way, in a multitude of ways as well. So now reaching for something that actually makes sense is an embryologic, we'll call it mistake, at 6, 7 weeks gestation, when the uterus, fallopian tubes, cervix are formed from downgrowth of these two tubes. Importantly, then, how do we make the uterus? We take a sort of a rubbery collagen scaffold, run it down as a template upon which to build some muscle, and indeed that comes down, and then the muscle is added on. And in that construction site of the reproductive tract, imagine somebody goes in, like any house that's half built, goes in with black spray paint and just randomly spray paints and splatters paint here and there. And it lands on certain structures or certain parts of the house that are already built, and will not land on things that have not yet been built. The cupboards that come later will be clear of those black paint. Anything that was prior there is at risk for having get black paint on it. So too in endometriosis, being a somewhat, we'll call it random, the idea is the randomness of a mistaken displacement of this origin tissue that will ultimately become the menstrual lining in the right place. Stem cell origin cells being, in a sense, left behind like a very untidy construction site. And therefore, those spots become endometriosis. But again, could it be two stem cell precursor layers up? Or is it one? Or is it three closer to the even origin cell for that menstrual endometrium? So now you can invoke the idea that, yeah, endometriosis at the subcellular level, this looks different than that menstrual tissue over here. That looks different than the menstrual tissue normally placed. That looks different than etc. So you get both a similarity simultaneously with a difference at the subcellular level between those spots of endometriosis and the true endometrium. So now that's the only, you can't invoke the idea that you backwards menstruate and then suddenly there's a cell turnover that changes it to a different cell. That just doesn't make sense given the plethora of different cells that are out there that are expressing as endometriosis. And lastly, so too, like whoever, PhD aside in cell biology, whoever would think that you could take a benign cell that's dead, menstruated off, half dead, or heck, I'll just give it credit for it, it's fully alive, that's benign cell would slide out through the fallopian tube, randomly settle down over there, and then have a second life growing again. We do not have that as a cellular mechanism, except in cancer, because that's an immunologic disaster. And please tell me if that proliferation of cells that I have going on in my intestine, I'm making millions of cells that line the inside of my intestine every day. Please tell me if I've got intestine growing from my nose as a cell mechanism that I'd have to invoke if I allow for endometriosis to occur that way. So now we have the idea of, oh no, I can't believe that because it can't be, it's got to be backwards. Okay, fine, backwards menstruation, but you have to invoke that that's the only cell in any organism, in any mammal, particularly in the human female, oh, not males, they don't do this, but only in females will we invoke the ability for cells to grow again on a second life. And it just never makes sense from just an instinctive, intuitive level. And now, if we get a new origin paradigm, we now have to then say, okay, if this one single event of an endometriosis being laid down, all the full dose of all the endo a woman will ever get given to her at 6 weeks fetal age, gosh, then it opens up the door of possibility that if I today take all the endometriosis out, all of it, not give weak excuses that, oh, it was next to your bowel or next to a critical structure that I didn't want to injure. If I take all of that endometriosis out, that woman, after her next menses, will not have a new dose of endo. That's not how she got it to begin with. But we will, after her next menses, she will still not have the endo that I took out. She will still, 2, 3, 4, 10 years later, she will still not have the new endometriosis or the endometriosis other than what I left. Hopefully not. Now, that finally being said, there are other things. Oh, that's right. The adenomyosis with still an extant uterus can have its inflammatory effect through the body, to your point that it's an inflammatory condition. And likewise, that adenomyosis can create hard, cramping, central pain radiating into the back and heavy disrupted bleeding as well. So I give to you an origin paradigm begetting a different treatment paradigm that has a hell of a lot more rationality to it than does a backwards menstruation. The kiddo, if we invoke the idea that it's a 6.5 weeks gestation, laying down of all the endo a woman ever get, then of course the 8-year-old will have endo. It's just starting to activate as her ovaries start the process of learning how to make estrogen. And of course men have it. Not often, but very commonly shared is the reproductive tract that I never built because of my XY chromosomes, but I've got remnants of that female system at the base of my prostate. And guess where the cases of endometriosis show up? in that female system remnant that's at the base of the prostate as diagnosis of prostatitis. Now we know that it's a static disease, that you don't get more of it over time. That bottom line, though, is you get the one dose, whether it's a lot or a little. And all of the things that were inconvenient truths to the origin theory of backwards menstruation now come clear and are understood with what is a single event, single embryologic event, all the endo a woman ever gets given to her, laid down at 6 weeks fetal age. One last thing, and then I'll shut up. And that is the following. Person will say, "Oh, all well and good, kid. I challenge you. How is it? How is it that it can be up in the lungs?" Well, how common is that? Incredibly uncommon, if not rare. But guess what happens to separate the chest cavity from the abdominal cavity? The diaphragm, the breathing muscle, grows over and separates the north chest cavity, lung cavity from the abdomen. Guess when that diaphragm closes? 7.5 weeks gestation. So we are all one cavity sharing different things up until that separation occurs. Well, as I said, the endometriosis is laid down at 6.5 weeks. So absolutely not common, but it can be shared up through the chest cavity as well. Anyway, now I will shut up.
No, this was, as somebody who was told they had endo 30 plus years ago, that's more information than I ever got from all of the doctors I've ever seen combined. It's amazing. And I'm so glad that, you know, there are people like you who are working to change these stories so that people aren't getting told the same.
And if I may, even through a blurry Zoom, I saw some tears in your eyes as you were.
You healed something in me. That was,
Yeah.
I think this is,
When
yeah,
I
it's
mentioned that
hard.
before, telling you about what you'd been told, and you said, "Yeah, that was me," I could see,
Yeah.
a little bit of tearing and stuff like that. And I'm sorry for you. But that is also just to say as well, there is a psycho-emotional trauma around being told as an 8-year-old, 9-year-old, 10-year-old, being gaslit is the favorite word these days, but being told that what your most basic human instinct, your most basic mammalian instinct is that something is desperately wrong. This being told that that's normal. And what that does to one's sense of self by being told that what you feel isn't, that what you feel is, quote, normal. And it shows up best sometimes when you see that 12-year-old who, as they're negotiating the healthcare system, is asked, "Show us on this pain scale, dearie." Um, and they go like this, and they see the smiley face and they see the frowny face, and they say, "There's not an option on here that I fits me." "Oh, you're so cute. Where did you get her?" says the well-intentioned person. And they say, "Okay, we'll just have to pick one." "Well, there's not one on this." "Oh, well, let's do a numerical scale. 0 being no pain, 10 being maximum, worst pain ever. 20, says the 12-year-old. "No, no, no. Where did you get her?" etc. 20. "Oh," comes the response, "you're being a little dramatic." That's at age 12. You're being a little dramatic. That's at age 12. Fast forward 15 years as that person has made the wandering through providers who have constantly said this is normal or whatever. Finally might find somebody who then says, "Ma'am, tell me what your pain scale is." She learned at age 12 not to say 20, and she learned therefore to say 10. Now, importantly, she dragged herself out of sickbed not but 2 hours earlier, put on makeup, lipstick, etc., got dressed for the first time out of her pajamas, wiped the residue of ibuprofen that she'd been munching on for the last several days, says 10, and guess what the response is? The response is not, "You're being overly dramatic." No, the response is, "Gosh, you don't look like a 10. "Oh, I get it. So you told me I was being overly dramatic when I was telling you what I felt before, and now I'm I'm succumbing to sort of the routine of all this, And now you're telling me I don't look like that. So please, everybody, tell me what I should look like to properly demonstrate, without being accused of being dramatic, what I should demonstrate to get across the point that I have this ungodly, unworldly type of pain that I have no ability to describe, but you're trying to tell me it's all normal. That sparks outrage in me. But I've seen the trap, and that's one of many psychoemotional traps that women who have endometriosis get caught up in. And no wonder they develop anxiety. No wonder they develop depression when that basic sense of self is being told that you ain't got that right. You don't have that basic sense of self. Yes, anxiety and depression, but let me finish the real cruelty. Person comes in and they ask them, "Hey, do you have any anxiety or depression?" Her real answer should be, "You're damn right I do, because you guys been blowing me off for the last 20 years and telling me that what I feel is wrong." But no, what they say is, "Yes, I do." Oh, and here it comes back again. Oh, well, anxiety or depression can show up as pain that you have. So now, here's the demonic part. That whole part is twisted back. And I don't just want to talk about endometriosis creating that psycho-emotional trauma. It is deep trauma, but it's also infertility and running through the gamut of infertility, where there's basically this instinctive thing that says, maybe I'm at fault here. I'm the one, I'm the one who's faulty, etc. That same twist is occurring and subtly exposed to patients who are seeking to add their family, and they go through the infertility mill. And so that's another place, not just on the disease side of things. Yes, they share, because probably, I don't know, I can't remember exactly, but 60, maybe 70% of women who are in fertility treatment have endometriosis. And I have a lot to say about that.
Well, and it's so frustrating because you're blown off for so long and told like, oh, it's probably, if you get pregnant, it'll get better. And then you finally get to a point where you're trying to get pregnant. You're not in high school and it's preventing you. And now all of a sudden this is taken seriously as,
Yeah, yeah.
something that might be worthy of attention by providers.
Oh, it's unbelievable. Yeah.
It's frustrating.
Frustrating. And not to make over much of it, but it is harmful. It is harmful to sort of hear that. And no wonder, and understandably, and actually appropriately, patients with endometriosis and infertility, they are pissed. Once their eyes open up to sort of all of this stuff, they are really angry. So now here's the other part. Guess what? We thought it was hard enough for well-intentioned gynecologists to take care of patients who have endo. And indeed, 60% of residents graduating currently do not feel prepared to take care of patients with endo. And as a consequence, well-intentioned practitioners or otherwise demonstrate competence will go, whoa, an endo patient, tell them I don't have any appointments, etc. But if they do take them in, angry patient comes in, and the anger is a whole additional thing, wherein practitioners end up saying, "Oh my God, have I got a cuckoo here? She's all pissed off, and I don't want to be the object of her anger, etc." So it just keeps cycling back, worsening the whole situation. And I'm not arguing one bit that patients shouldn't be pissed. In fact, that's the only way in which this advocacy, and indeed the advocacy that's being driven, is driven not by a bunch of laggard physicians like me who just are dragging our feet about making changes, but it's being driven by patients who are pissed enough to move this forward. Thank God somebody's doing it.
Yeah. Well, yes. And I mean, I think the anger and the trauma, really, the additional trauma caused by not just the condition, but the way they are treated within the systems that are supposed to care for them, just add to their suffering in a way that I know makes us all very upset and angry. But that can be a great motivator for advocacy. And
Indeed.
I'm always so amazed and impressed with how advocates in the endo community are able to channel that really deep trauma into very effective advocacy, because
Yeah.
you do have to kind of play the game a little bit and be forceful but respectful, and they do an amazing job of
Yeah.
doing that, even though that's incredibly hard to ask a very traumatized, angry person
Yeah.
to do. Well, speaking of advocacy, can you, I am very proud to be a co-founder with you of the Endometriosis Alliance of Massachusetts, which has
The team.
the great acronym team. Yes. And so, can you talk a little bit about, because I feel like, I mean, we definitely could talk a long time about the problems, but I definitely want to transition to some of the progress that's being made in improving things. And you're really at the center of two of them. And one is advocacy, and then we definitely want to talk about the training, the provider training that you're doing. So we'll start
Oh,
with
you're very kind.
advocacy and
Yeah.
team. What excites you about doing advocacy like team? Because what do you feel like is really needed?
Yeah. So I think if you, and not to be analytical about it, because so much emotion is in it, but nonetheless, the idea that where do you start? This huge problem of a huge failure within the Western medical care, and we're not, other countries are not immune to it. There are some greater enlightenment, certainly in England and France and even Australia and New Zealand, about dealing with endo in a more comprehensive way. But nonetheless, you have to start at the top and you have to start at the bottom. It's awareness at the bottom and awareness at the top to give people a sense of, and I'll call it the sort of social injustice that we have created out of a well-intentioned and loving healthcare approach to endometriosis. At the top, it's getting legislators who make laws and who hold the insurance companies to heel about covering this. It takes going at the legislative level to the, what is it, CMS, to have the people who ascribe how much is paid for something versus how much, how we allocate our healthcare funds to make sure to and hold them to task in terms of aiming appropriate research money and even direct patient care, aiming money towards that really reflects the burden of the disease, 10% of women with some complete disability, but aiming the money to the heart of the disease in a thoughtful and appropriate way. Keep going down that path. It's getting societies and docs aware of what? It's not retrograde menstruation. No, if you want to be current, think of something other than from 100 years ago. And so now we get down to, is it the school nurses? And indeed, well, the school nurse initiative that was just absolutely genius. And Shannon Cohn's films. And then we get down to, gosh, parents and pediatricians and at the ground level for healthcare. And and then lastly, it is, um, emboldening emboldening patients who feel like they've been wrong to not disengage, but to engage. And to your point, yes. And when I'm asked, hey, what can I do? What can I do? And I frame it as, in a sense, that somebody walks in the door who's been traveling the Endo Odyssey, meeting every, 20 physicians and getting misdiagnoses for, from whatever, um, is to that they have earned their Endo Warrior badge level 3 just by having lived with Endo. So now it's a way to kind of frame this as a crusade, we'll call it. And by going through surgery and having had all the outrage pointed to them before, going through surgery, realizing wrong paradigm, realizing all those other things, realizing that all of that is a badge of honor, that you've endured and lived through this all and are coming out the other side with pride, then wear your Endo Warrior Badge 7 and then turning that and taking that forward and being an Endo Warrior. So I have tried to, maybe it's just a silly thing, but nonetheless, to sort of frame this as, what can I do? I'm sorry, go to war.
Yeah.
Everything's a war these days, but
Well,
go to war and be, to your point, respectful but fierce,
yeah.
absolutely fierce.
Well, and I mean, it's not obviously it's not silly to us at all. And I mean, when I say our day testifying with members of the endo community last year was one of the absolute highlights of 2026. It was so difficult, but at the same time, so powerful, so empowering, and to just see people sit in their power for the first, not for the first time, but in that way, a lot of them had never been, testifying. And it was just so awesome. And it was so special for you to be part of it. Many of them knew you as their doctor, but then to see you in this context was, I know, very emotional for them. So can you talk about the training? I know you said you're retired,
Yeah.
but it's really like semi-retired. You're retired from direct
Yeah.
care
So
and surgery.
I'll give you just an example. Next 2 weeks is a good example of my retirement. Anyway, I fly out tomorrow morning to England to talk to an institute regarding setting up curriculum for excision of endometriosis. Now, I'm meeting a colleague of mine in England who's one of those magnet or one of those. He is one of the centers of excellence in England. Oh, what an enlightened thought! A stage 3 and 4 endometriosis patient cannot be operated on just anybody. They have to go to specialists who actually have to give show a driving test every year, do a driving test every year. They have to submit films that demonstrate their skill set in real, and they have to submit their case list, etc. So, so I'm going over there to this enlightened country somewhat. They do it better than we do. Um, and we're setting up training programs for endometriosis excision. Then I come back on Friday and then I spin around and go out to, I think, God, I can't remember, St. Louis or whatever to talk about a curriculum there. And then I come back and I've got a fellow, an endometriosis excision fellow, who is mid-career said, I got to learn this disease. And so I spend 2 days training her Thursday and Friday. She being one fellow out of a total of four who will be then taking an 18-month fellowship in endometriosis excision. So, how am I doing that? Well, I developed these really high fidelity, well, what are called real tissue models. And then I've built around them since 2011 or so, built curriculum for training surgeons on how to operate, what the instruments they need, how they manipulate them, etc. So this fellowship is 18 months. Four people have committed the following amount of time. It's a fellowship that's based also on the idea of an executive MBA. If I wanted to keep my job, keep paying my mortgage, keep paying all the things, and actually like stay with my family and not have to move away for 2 years to get an MBA. And these are very common. I just go to some university that offers an executive MBA. And yes, I'll go in for 3 intensive days about every month or every other month or whatever, do the in-person event. And then afterwards, guess what? I got a lot of homework to do over this period of time. But at the end of a given period, I've got a MBA. So why could that not be something that surgeons could do? They've got a lot of the knowledge. They just need the hands-on stuff to learn technique regarding endometriosis. So I've extrapolated, I simply stole from the concept of an MBA, and we have now the first executive fellowship in advanced endometriosis care, albeit in simulation. But these are four very dialed in mid-career surgeons who have had enough patients come in the door to remind them that they are inadequate in treating endometriosis, that they're willing to put 18 months and 3 days every other month carried out over 18 months. So that's got 38-hour days, plus they've got another 100 hours of home work, plus a whole other bunch of different stuff that they have to do. So it's really exciting, and this really puts endometriosis into a fellowship realm that is approachable for people who want to learn this skill set. And my absolute confidence is they'll be able to deal with stage 1 and 2 disease out of this fellowship and most of stage 3 disease. Now, the stage 4, which what is 10% of patients, they will have been able to now effectively treat 90% of the patients that will present to them. And that's a huge impact, I believe, with then the scaling up of that. So, gosh, if I had the energy, and I literally just last week had the first 3 fellows of 4, one from Indiana, one from Pennsylvania, and the other from New Jersey. And this fourth fellow, unfortunately, could not attend the first session, so I'm getting her up to speed next week for 2 days of intensive one-on-one work with her. But anyway, so now the concept is, wow, we could have had this coming weekend another 4 or 5 fellows. Then the following weekend, Friday, Saturday, and Sunday, start another cohort, start another cohort, start another cohort, start another cohort until that first group, cohort number 1, swings around 2 months out and comes back to occupy that weekend. But now you do the math, and now you're getting 100 new endo surgeons out
I love
about
it.
every 18 months. So that's the vision of, and the company, not it's a nonprofit surgical education and training company that I started, and it is really heading up this sort of way of getting people trained in a method by which they do not have to, give up their job and walk away from their family and all their debts, etc. Anyway.
Yeah, that's amazing. And thank you so much for everything that you've done over the course of your career for endo patients, from, you know, working with patients one-on-one to the advocacy work they're doing to ensuring that there are providers who are coming up who can actually understand and treat this disease. It's amazing.
Yeah, but I will tell you, I am a follower. I'm still a follower in this. The real leaders are those endo warriors out there, truly, who are pushing this forward and saying this has to happen, this has to happen. Because with that, I can function much better in the wake, not a funeral wake, but in the wake of a good boat. You can do a lot better skiing in the backside of a wake than ahead of it.
Well, couldn't ask for a better partner in the work.
Um,
So there are 2 questions that we like to ask all of our guests. And
yeah.
for you, I'm assuming we can, go with your unique perspective. But the first is, what is one thing that you would say to somebody who is just starting to grow their family?
You probably get a sense, and this is maybe a ham-handed answer, um, but be fierce. Not just be fierce in one's self-advocacy, but fierce with an optimism that will not be resisted. An optimism, I will do this. Because what that does, I believe strongly, is emotionally, it takes away oh, dear me, I must have done something wrong. Oh my gosh, I had an IUD placed at 16. That must be it. Oh my gosh, I had a termination when I was 17. That must have done it. So all the things that will pile in to this self-blame. And one of the antidotes for that is to say, I will do this. I will achieve this, and let no one dissuade you from that. And so that's it's a maybe a ham-handed answer, but it nonetheless is really, it gets at this. One has to be um, just this fierce advocate, a force unto itself, so to speak.
I love it.
All right.
And the second question is, how can somebody show up for a friend or family member who is either struggling to build their family or maybe struggling with endo, if we want to broaden it a little bit?
Yeah, yeah. No, and I think easy to say, but really tough to do is just be the listener. And sadly, I've heard it 100 times over. Oh, you poor thing, you're not getting pregnant. And now comes sort of that unwanted sorrow for them. What comes then is don't you worry, honey. You just, etc. It's very different than this fierce optimism felt by the patient themselves. But it's sort of this situation of I don't know, and it's mean to say this of well-intentioned people who are trying to help somebody, a friend of theirs or whatever, through, or family or whatever. But avoiding avoiding the urge to step in and try and make right and help and stuff like that, when really just listening is a huge help. Validating all the conflicting emotions, etc. And that kind of is also endo, validating what they're feeling. And and the fellow said, well, what do we do this last weekend? And they said, well, I've got this patient who I don't know if I want to take her to the OR or whatever, for the endo. And I said, take her to the OR. Tell her she's got endo. That's the biggest gift
Mhm.
you can give her. She's got some
Yeah,
reason finally, after 20 years, for all the symptoms she's been having. What a
I
gift,
know.
even though you
Yeah.
can't
hmm
do anything about it.
That's
So
one of the
just
most
knowing.
powerful things for me is that this is almost unlike any other disease I've ever heard of,
Yeah.
in that the patient wakes up and their biggest fear is that you're going to tell them they don't
and,
have it.
yeah.
Because then you
And
start believing it wasn't all in your head and everybody
right,
was right. And yeah, that is the
exactly.
biggest thing that you can do, is to
And
validate and to acknowledge that, no, this is real.
Yeah. And to your point, Kate, along with that after you tell them, they're in this fogged state too, as well, but
Hmm.
clear as a bell, they say, did I have endo or not? And what happens as well is you say, yeah, you did. And I'll show you pictures of it in case you doubt me. Because I've had patients who will see the pictures, bring them back and say, are you sure I got endo? Look at it. It's right there. Well, I thought you might have gotten, I've heard this. I thought you might have gotten my pictures mixed up with somebody who doesn't have endo. So sealed into people's head is that they've been making this up. Anyway, and it's true
Yeah.
of fertility issues too. It must be my
Yeah.
fault. I must have,
Hmm.
etc. And so it's just the listening, I guess. So those are hardly answers, but
Oh,
none.
No, those
they
are perfect
absolutely
answers.
are. Thank you so much. And
None at all.
especially not to have gone through fertility struggles yourself. Those were very thoughtful and inspiring answers.
Yeah.
So we're glad you didn't struggle with infertility yourself. But um, thank you so much for being on the podcast, and as we said, for everything you do.
Yeah, well, back
Mhm.
at you guys for doing this. This is the hard advocacy work that you have stepped up to. So congratulations.
Thank you.
We're
Yeah.
happy to. Speaking of advocacy, are there any current calls to action that team has?
So team is supporting legislation currently in Massachusetts to create either a task force or a commission focused on endometriosis. And information about the bills is on our All Paths website. And it is definitely not too late for people to advocate. These bills had their committee hearing already, but they are not through the process yet. They have to pass by the end of July. So definitely follow the steps that are on our website in terms of how you can reach out to your own state representative and state senator if you live in Massachusetts and ask them to support this bill. And all the information that you need to do that is there. But if we can help you too, feel free to reach out to All Paths.
And I don't have any serious comparison points to make, but it's a very well worked out cheat sheet on what to do and how to do it. So it's for me, from my point of view, it's definitely idiot proof to to know, tell you what to do. It really holds hands and takes
That's great.
even the uninitiated legislative advocate, it takes them through that process well. So Kate, thank you.
That's what we want. That's great.
Thank you for the opportunity to get.
Thank you
Thank you.
so
Well,
This was
much.
wonderful.
thanks again.
We hope you'll join us next time for more family building stories and resources. Be sure to subscribe wherever you listen to podcasts to make sure you never miss an episode. And follow us on social media at All Paths FB, or visit our website, allpathsfb.org, for more information about our work. All Paths Family Building is so grateful to the members of our circle of support who are vital to our ability to provide emotional support, education, and advocacy that is open to anyone struggling to grow their families.
Today, we want to thank our rainbow sponsor, Granada Bio.
Thank you for joining us for this episode. Please help spread the word so that anyone who is struggling to grow their family can join the conversation. It's an honor to walk with you on your family building journey.